Um, uh, recording in progress. So yeah, so yeah, given that this session is really small, um, I actually want to change the format a little bit if that's okay with you. So yeah, would it be okay actually to kind of get to know you a little bit, and kind of I'll be introducing myself kind of after the kind of the round, but it'll be nice to actually have it more like a close discussion between us, and I'll go through the slides as quickly as possible to give you back the time. But what do you think? Yeah. So Alina, would you mind actually giving a bit of background, and then we can do a bit of intro each other? Yeah.
I'm sorry. Well, you want me to?
Yeah.
Okay, yes. Hi, my name's Alina Jacob, and I'm a program specialist at Mental Health America of Greater Houston. I've been here a while, and we host echoes for people like you guys so that you can come together and learn more about your field and what you do. So that's me.
Thanks, Alina. Yep.
I'll go next. Hi, everyone. My name is Sujina Perajuli. I'm the program manager for our Integrated Healthcare Initiative program. Our program is focused on everything related to integrated behavioral health, and part of that is also value-based care, which of course goes hand in hand with integrated care. So we started this series, and this is actually going to be our last one. So yeah, it's very nice to have you kind of close us out today, Yubin.
What an honor.
I can go next. I'm Courtney Hastings. I'm with Hurt Family Health Clinic, and we're a federally funded healthcare clinic. I'm the director of nursing and risk manager here, and happy to join.
Nice to meet you, Courtney.
I can go next. My name's Erin Tobin. I'm a clinical health psychologist and the director of the integrated psychology team here at Henry Ford in Detroit, Michigan. I'm really interested about this conversation today. In our state, only the collaborative care models are getting the value-based uplift. So I'm really interested to hear how some of the more psychology-driven models could also do that.
Nice to meet you, Erin. Yep. And we have Christopher and Patrick and Victoria. Yeah.
I'll go. Hi, everyone. I'm Victoria Salgado. I am the program support specialist for MHA. So I just do a lot of like the behind the scenes backbone stuff for our team.
Nice to meet you, Victoria.
And I'm Chris Hunter. I'm co-director of CNC Hunter Consulting, recently retired from the program director for the military health system for primary care behavioral health services. Just looking forward to learning this morning. Thanks.
Nice to meet you, Christopher. And Patrick. I think maybe I can go next. So and thanks everyone. Actually, sorry to put you on the spot. I know this is not a usual kind of format, but given that the session is fairly small, I decided to actually have everybody involved and get to know each other. So my name is Yubin Park, and thanks for joining today's session. I'll give a bit of a intro to give you a kind of exactly who I am and why I'm talking about this topic. So my background is in engineering. So I got my PhD from UT Austin, and I believe Sujina, are you from are you in Houston?
Yes, we're all from Houston, actually.
Oh yeah, it's really hot, and I've been to Houston many times. So all I remember is whenever I actually open the door from my car, actually, my glasses just fog up. So I lived in Austin for a long time, and I started my business right at my school. So it was about 10 years ago. So that actually puts my career about 10 years, kind of not that long compared to a lot of people here. So I started my business in the Medicare Advantage space. So I did a bit of a software engineering, did a lot of risk adjustment suspecting algorithms And then that business was sold to Evolent Health in DC, so that they provide a lot of value-based care services for ACO. And I think these days they do a lot of risk contracting for plans as well. And I stayed there a little bit. And I studied another company to do some value-based care analytics for ACOs. We actually helped out a few California ACOs for Medicare. And I ran the business about 2 years. And I eventually sold the company to a company currently named as Ashrana Health, and the formerly known as ApolloMed. And there I was Chief Data and Analytics Officer for about 2 years. Then around March, I came out. And at the moment, I describe myself happily unemployed. But at the moment, kind of doing a bunch of different things, like this kind of session as well. And today actually it is a bit unusual topic. So I actually never prepared a slide this. But when Sujina asked that I need to talk about value-based care and dashboards, and it also got me thinking, okay, what should I talk about? Exactly what I'm going to talk about this dashboard and value-based care. I made a lot of dashboards in my past. And then I was thinking for many days. I was actually traveling in Korea for about a month when actually I got asked to present. And after for some time, and I decided, okay, I created a lot of dashboards in my past. And literally for the 10 years of my career, actually almost every day there was no day passed without creating something, usually data visualization, something that is related to dashboard. I did a lot of dashboard work. And to be honest, I failed a lot. Meaning that I don't think actually I created maybe 1 or 2 useful dashboards. I don't know, maybe I may have created almost nothing that is useful. And I decided to compile why I think actually those dashboards failed. And what can we learn from there? And what kind of things we can do better? And actually that gave me an opportunity to think about what exactly is dashboard and how should we use them. So that's the topic I'd like to introduce. So for the today's discussion, I would love to actually get interrupted if you guys are okay. So I actually as my side job, I also am an adjunct professor at Emory University. I live in Atlanta, Georgia. I teach machine learning course for the Emory graduate students at the computer science department. I actually did a lot of teaching during COVID. So I actually am quite familiar with this online lecture. But the one thing actually I found useful is that when actually people interrupt me, I feel like I realize that I'm talking to someone rather than me talking to my screen. So that actually puts me back to the actual regular cadence. So if you can actually just interrupt me, even without actually having anything to say, just call my name or something like that. That helps me put me on the track. So please interrupt me as we actually progress. So do you guys all see my screen? Yep. Perfect. So I'd like to tip off the conversation by asking this question. Do you like your dashboards? So yeah, I see Courtney rolling eyes. So we use dashboards, and it's dashboards all the time. If you're a manager of an organization or managing a team, managing a clinical process, whatever you do, I think dashboards became an integral part of our daily work. And the funny thing is, I also use a lot of dashboards. And I usually have a bit of a love and hate relationship with my dashboards. So aside from my actual work in healthcare, I'd like to actually ask you a question. What other dashboards do you look at outside of your work? Anyone? One thing actually you guys may not realize is I look at my stock portfolio all the time. Do you look at your 401k dashboard? Do you look at your brokerage kind of account? Do you look at your bank account? That's actually dashboard. And the people do not realize actually that's the dashboard. Actually, people look at almost every day. I also look at a lot of other dashboards. So the some of the dashboard is, and actually this is the original dashboard that the term created. When you're driving, you look at the speedometer. That's a dashboard you look at, right? And there are other dashboards I look at. Or I have many websites I manage. I look at my web analytics dashboards all the time. Who visit my site, who is coming back again, and all those things. I use our dashboards all the time, but somehow those dashboards feel a little bit different from the dashboards I use at work. And that's kind of where my question started. So this is just kind of a bit more detailed question on the do you like your dashboards? And I believe many of you already are familiar with the value-based care. So just want you to think about, if you like your dashboards, why you like it, and if you don't like your dashboard, why you don't like it. And can we actually elaborate the reasons why I don't like it, why we like it, right? And I want to actually think about exactly, was dashboard really necessary for the task you're doing? Is there a different way to do it, right? So this is my background. So just gonna reiterate what I exactly have been doing in the past. So let's dive deeper into the topic. So before going into the real discussion, any questions so far? Anything you want me to cover beside this? Nothing? All good? So I been putting together the reasons why I've been maintaining my love and hate relationship with dashboards, and this is essentially the hate part. Why do we hate dashboards? And this actually you may have experienced directly or indirectly or frequently. So I actually personally experienced this situation quite a bit. You ask one analyst a very simple question. Analyst gives an answer. Next day, you ask the other one, and the person says different answer. Which one to trust? Everybody says different answer. And I don't know, even I can even trust anything out of these data. It's not just analysts, but when you create the dashboard, actually a lot of those answers can be very different when you're asking the same question. As actually you interface with the many different dashboards, you start to question, is this number accurate? And why actually things are actually different when you look at the one or two more dashboards. I don't know if you guys actually ever experienced this kind of situation in your work. So Alina, so sorry to put you on the spot, but have you actually experienced like this situation before? No? So in value-based care, it happens quite a bit, and even actually we actually have different numbers between Centers for Medicare and Medicaid Services (CMS) and ACO. I've been in Medicare Advantage and ACO operations for some time. Even a simple question like, how many members do you manage? Answer CMS may give you will be different from what you think. And if you ask a different consulting company, Milliman, Wakely, and all those guys, they may actually give us slightly different answers too. And it's actually those simple questions. Actually, they actually tend to be a little bit more sophisticated than it looks. And the another hate part that I have with the dashboard is it's often too late. So the chart on the right shows the some comparisons. According to this chart, it takes 2.3 minutes to get an Uber appointment, right? 18 hours to go to Singapore. 48 hours to get the international delivery, right? It takes 4.5 business days to update the dashboard, right? That's industry average. And I believe actually in healthcare, if you have a 4.5 days delayed dashboard, I think it's a superb. I don't know, so there are all the dashboards you have. There may be something near real time, but a lot of dashboards I created in the past, it's at least 30 days to 6 days old data. A lot of dashboards we create are based on the claims, and there's some EHR data that has an inherent lag between the actual event and the presentation. And when you find some information on the dashboard, the ship has already sailed a lot of times. And that has been a bit of issue for me. And another the last issue I had with the dashboard is we often create too many dashboards just for the sake of having more dashboards. So my last job, as Chief Data and Analytics Officer, I actually literally had like 500 or 600 dashboards in my company. It's a big company, by the way. But the thing is, people create dashboard easily, and there are a lot of tools to make create dashboard easily, and you can create dashboard for a lot of different tasks. But after you create the dashboard one by one every day, they accumulate, and they start to accumulate, and a lot of them won't be used. So you actually start accumulating and then making, a lot of dashboards that actually you don't even know those exist, right? And those actually create the different views of the data, and it actually make you a bit more confused about the data. It's information overload. And putting these together out, these are the reasons why I actually have been disliking the dashboard. And I started to question exactly what is dashboard? Why do I not like those aspects of dashboard? And where is actually this discrepancy is coming from? Why actually my expectation and the reality of dashboard are different? So then I decided actually it may be because I don't quite understand the nature of dashboard. I think it's time to revisit exactly what is dashboard and understand that. I'll stop here, and I don't know if you actually have any questions so far. Nothing? Am I going too fast or too slow or too boring? Is it something you already know? So I'll give a bit of an overview about the dashboard. So I did a bit of web searching and read a lot of articles. And funny enough, we use dashboards almost every day, but there isn't much of a actual definition of dashboard. There is no course for dashboard. There is no master's degree program for dashboard. We use dashboard, and there are a lot of different definitions about the dashboard. It's like AI. Once it became a jargon, and the people use the word over and over, and the original meaning of such become very, very vague. And I think a dashboard is like that. So when you actually collect all the different types of dashboards, and now we are kind of evaluating what is exactly dashboard. So when you look at all the dashboards, you can actually group them into these 3 buckets, or some dashboards have a mix of these, right? So the one is operational dashboard, and strategic dashboard, and analytical dashboard. So I'll give an example in the next slide, but let's actually read it out. Operational dashboards are the ones that monitor the current operational status and provide prescriptive or detailed guidance to improve performance, right? And on contrary, strategic dashboards track KPIs, key performance indicators, to evaluate the current strategic direction and the long-term plans. And the analytical dashboard has the best of the both worlds, right? To actually make it a little bit easy to understand, I put on kind of analogy like this. So when you're actually driving a car, do you guys use a Google Map? Right? And this is essentially an example of an operational dashboard. It's intuitive, simple, and it gives exactly what you need to do. Turn left, turn right. Something is 30 feet away or 1 mile away. Take this lane, take the second to left lane or something like that, right? It should be simple and intuitive and actionable. Most importantly, it should be up to date, right? It should be timely. On the other hand, strategic dashboard is a little bit different. You can imagine that you are actually having a long road trip, and a day before the trip, you are looking it up on Google Map, and looking the patterns of the roads, and seeing the heavy traffic pattern of the given time, what are the roads connecting to a point A, from point A to the point B, and just kind of getting the kind of scope, and having a long-term, kind of overall plan for the trip. And the dashboard that actually help you do that is called the strategic dashboard, right? And the analytical dashboard, as I said, it has the best of the both worlds. And the screenshot here, I don't know if you guys actually watched this James Bond movie, Skyfall. Maybe not. So if you're familiar with the James Bond, the Skyfall. Oh yeah, Patrick, thanks. So the Q works in headquarters, kind of engineering genius. So the is helping James Bond with the earpiece, remote earpiece, telling exactly where to go, looking at the complex underground tunnel patterns and the tube maps and all those things, looking at the historical patterns and the old maps and the current map and all those things, doing the complex data analysis and giving the exactly what to do, right? It's looking at the both planning as well as the real-time information. That's called analytical dashboard, right? And how these actually kind of dashboards get divided. And I've been thinking about this a lot, and this is my answer. And the kind of things may be a little bit different from person to person, but this is the best conclusion I have at the moment. Data recency, means actually how up to date the data is. Data recency determines the types of dashboards, right? And also kind of there is another factor in intervention window, right? So exactly what you want to do with the dashboard determine the type of dashboard as well. So on the chart, what you see, the x-axis is the data recency. The left means old data, like a 3-month year, old data, or 1 year old data, or something like that. The right side will be the recent data, a day old or 1 hour old, or real time. On the y-axis, you will see intervention window. How fast you want to act on, the data. Is it transitional care management? Should I call the patient right away when they get admitted? Should I call right away when they get discharged? Should I just intervene at the right time, given 1 hour, 2 hours window? That's the effective intervention window. And the upper we go, and it means a shorter intervention window. And the down, it has a longer. And you can be late. You can be a 3-month late, a 6-month late. And when you actually put down these 3 different categories of dashboards, you actually can put these into these way. So what you actually will see is a top left. It's a kind of no use dashboard, right? So the type of information I want to use needs to be on time, up to date. But the data is old, then actually there is no use. A lot of times, actually, we have a lot of these dashboards in our lives. Dashboard showing no information. Well, it shows information, but essentially no useful information, right? On the other hand, top right, that's the operational dashboard. When you have something that is urgent things to work on, and you have the right data on right time, right? That is actually a dashboard that is useful, and that's like a Google map while on navigation. And you have a strategic dashboard on the bottom two quadrants, right? Strategic dashboards can actually also use both the old data and new data. But when you're thinking of the strategy, it's not the action you need to do tomorrow, right? The strategic dashboard means that actually you are planning mid to long-term planning. So the intervention window is a little bit kind of longer, right? So you can actually put those strategic dashboard into these bottom quadrants. And the analytical dashboards has the best of both worlds. So that's how they go.
Yeah, per your invitation, I thought I'd just go ahead and interrupt you. I like the way that you're presenting this because that dashboards, when they're done well, can be very useful, but doing them well can be a challenge. So it sort of depends on who wants the dashboard, why is it important? Is the data for the dashboard reliable? If you start a dashboard and it's a big project and the data is supposed to be reliable and then it's not, then the users start to have an attributional bias of why are we wasting all of this time? Can we really ever trust this data? And can we get informatics and the programmers and leadership and the clinicians all to contribute to the dashboard so it's a meaningful dashboard that, like you said, depending on what its use is, gives us information that is accurate, updated relatively quickly, actionable, and who's going to action that information? And can we do it in a seamless way that doesn't cost a lot of extra money and time for patients or clinicians? So how can that be drawn from your electronic health record? Who's going to do that? What's the delay? So I like how you're breaking it up because I think it can help our participants think about it in a different way. Different dashboards are for different people for different kinds of actions. And I think less is often more. And I think that is not necessarily a message that's given across the board of people that use these. And I'm interested if anybody else has kind of seen the same thing. Thanks.
100%. And thanks, Christopher, in so many ways. First, thanks for interrupting me. And the second, 100% agree. And it was actually a really nice segue for the next slide. And the nature of the dashboard, actually, there are so many stakeholders. And I don't know if you have seen this picture. It's a fairly famous diagram. It's also called as a Chinese whispers game. Have you played the Chinese whispers game? Yeah, right. So it's a you line up a group of people, and essentially the first person that gets a message, and they actually whispering to the next one, and see if the last one gets the original message. Because you're whispering, people cannot hear exactly what they're talking, so the message gets transformed into something completely different at the end. It happens all the time. So in any size of the organization, think about how many people get involved in creating a dashboard. There's a IT guy, database administrator, some analytics guy, and business stakeholders, and many times many business stakeholders, and sometimes different C-levels as well, right? Everybody wants different things. And often, actually, we don't sit on the same table. And those messages get transferred in a very archaic or chaotic way. And when you actually receive a product, and you may actually find this situation in real life, that what customer wanted was a very simple, tire swing. And all you get is a very different results, like this way. So the message here I wanted to convey is that let's try to understand the nature of dashboard, and then let's be smart about asking and choosing dashboards, right? So because as we understand the nature of the dashboard, we can align our expectation, and then we can actually be smarter about what to expect and how can we design the better dashboard. So which dashboard do I want? Is it operational or strategic? Often, sometimes you may want to mix both, but my personal preference is let's be simple and let's do one thing great rather than two things mediocre. Right? So but it's I wouldn't argue too much on it. It's a bit of a personal preference, but knowing exactly what you want, is it operational or strategic? I think sets the right expectation for the dashboard. If the operational, how would your operation change based on the dashboard? This is a very important question to think about. If there is nothing to change, then it's better not to have that operational dashboard. But you also always need to remind yourself exactly what you want to change based on the results that you see in the dashboard. For example, in a dashboard I see every day in my car, the speedometer. I change my action. If the speed is too high, I reduce the speed. Right? If the speed is too low, I increase the speed. Right? If my stock is tanking, I need to sell it quick. Right? If my stock is going up, I should wait and see. I mean, I'm not saying my investment strategy, but it's more about I have some idea about what to do as I watch the numbers. And we also need to think about when you're asking dashboard and when you're actually looking at the dashboard, we also need to think about exactly what you want to do based on the numbers. If it's strategic, how your long-term and mid-term plans would change. I think these are the things that we need to think about. And what are the data sources and their recency? We cannot build a operational dashboard with old data, right? That's just impossible as from the previous framework. So it's important to understand exactly what data sources you already have, and think about the limitations that bring together, right? How frequently are they updated? Also determine what kind of things you can do. What is the quality of the underlying data? Very important. And how are the measures defined? Also very important to align the expectations. So any questions before we go down into the type of data sources that are available in value-based care?
I loved your depiction of how people interpret similar messages, like speak different languages with their dashboards. Do you have any recommendations about how to overcome those barriers or ways? Because I think that's something we struggle with here, is that we ask for something and then we get different things from different data analysts, and then it's like a bigger conversation.
So unfortunately, I don't have any solution. Rather than, but the general guidance should be there. Erin, could you actually give me a bit more detail about the kind of situation that you actually usually kind of put yourself in? So you are the ones who, as are you the business stakeholders that ask the dashboards to the analyst? Yeah.
Well, I'm one of the leaders that even this morning I was asking for some metrics about a percentage of patients who have a certain kind of insurance and have a substance use disorder on their problem list, and I got two different very, very discrepant values from different analysts when that's a pretty specific question from my side. But I think what you were commenting on in terms of the speed at which these data sources are updated might have been different for both of them, or they might have been including different things. So that's just a real-time example from today.
That's no, actually that happens a lot, and I experience almost every day when I was actually working for my previous firm as well. So there can be multiple reasons, and to be honest, actually a lot of these things can be case by case, and a lot of different issues get mixed into one. One kind of probable issue may be the level of analyst. They may be actually understanding the problem a little bit differently. So sometimes it's actually a little bit helpful to describe what you want to do rather than what should be shown, in my experience. So Erin, if actually there is something actually you want to do after seeing the data, sometimes for analysts, kind of from the analyst point of view, because analyst being myself as well, So it's helpful to understand exactly what Erin wants to do with the data.
Okay,
Yeah,
that's
right.
a helpful way to think of it a little differently.
Because the devils are in the details, and the reason actually they are showing the two different numbers is because that they are filtering the data a little bit differently, while they may be tapping into different data sources. And the another actually way to tackle this problem is, although it's a bit more work for business leaders and business stakeholders, is that the business leaders also need to understand the limitation of these different data sources as well. So sometimes it's kind of helpful to give a bit more micro instruction. Use this data source and do this pre-processing and show me this one. Right. So it's kind of in many ways because a lot of things may get lost in translation, and these analysts may be using a lot of different data sources that is already created in the past, and a lot of these data sources actually may be there as a legacy from somebody who left the company in the past as well. That happens. So for example, in my previous organization, we managed like thousands of different tables, and who knew actually all those tables existed. And if you were to find some information that my manager asks, give me the readmission rates, give me something, and those numbers, seemingly similar column descriptions can be found in any table. And those values may be a little bit different across different tables, right? So sometimes it's a little bit arduous task, but it's better to understand exactly where the source of the data is, and what kind of pre-processing steps actually are going through, and exactly what I want to do with the data. I think that's a vertical kind of view from the source to the destination. I think we all need to have a bit of an understanding, not the kind of full understanding of the entire process, but a bit of understanding across the table will be immensely helpful. Sorry, I think I'm asking you to do more there. Was it helpful, Erin?
Yeah, no, that was really helpful. I think it
Yeah.
was that kind of a helpful perspective shift to think of how I could approach it differently with them.
But yeah, it's always a challenging. So because I also never solved the kind of perfectly, and in the end, I always hope for the kind of marginal improvement every day by having more conversation with the people. Yeah.
I'm sorry to interrupt, but I don't know if you addressed the comment that we received from Patrick.
Yep. Comment. So could you read?
Yeah, I'll read it out loud.
Yeah.
He said, we are working with the state and a developer on a statewide database. The developer has absolutely no understanding of I can't read the other sentence, of end users need. It's been 3 years of effort to fix the database.
I see. I think that sounds like there may be too many middle layers between actual developers and the stakeholders. So there may be one reason. I think there may be multiple reasons. So Patrick, so is State Department have the kind of direct communication channel to the database developers, or is it always going through multiple steps to the makers of those things?
I think Patrick is having a mic issue today.
Okay.
Okay. Another comment from Christopher, Dr. Hunter. It has been my experience that the users that want a database created need to spend time upfront with the informatics, analytics, and report preparers, etc., to make sure that idea is understood and to develop a minimal beta version first to make sure it is on target. And Patrick responded to your question. He said, we are finally all sitting at the table together.
Yeah. So it's a solution. I wouldn't call it a solution. It's not an easy way, but a lot of times we may need to do a bit more work altogether. So in the past, we always go through kind of regular channel of asking something to be done. But we have experience enough that going through the channel, kind of sometimes it does kind of get things done most of the time. But a lot of times actually we get a lot of useless dashboards. So it's because a lot of things get subdivided and they are specialized, and they things became very siloed. I think it's a time to time we need to sit together, as Patrick says, and also Christopher says as well. I think it's about actually having people aligned across different functions, and the dashboard. In the end, the true meaning of dashboard is actually have the information aligned across different business stakeholders. And I think to do that, actually, we first need to sit down together, and probably that's the only way. Although it's a little bit difficult way, but it's the only way to start solving the issues. So I'll move on to give a bit more detailed slide. So I have been dealing with a lot of data sources, and this is not all, but because today's topic is value-based care and dashboards, not just the dashboard. So I tried to put together what are the dashboards in value-based care are built from, right? So these are the kind of data sources I have utilized in the past, and I just wanted to describe some of these things and their characteristics one by one, right? And I believe there are a lot of other data sources, but these are some of the things I put together. So if you are dealing with the Medicare ACOs, there is a new data source called the BCDA. You can actually look up on the Google. So the type of beneficiary claims data API, BCDA, it's a file formatted Medicare claims data for Medicare ACOs, right? So actually they released the claims data before education. So as an organization that manages financial risk, this is actually a very valuable source of information, because you can tap into information a little bit earlier than it need to be. Right. So the claims data inherently it's a lagged. It's not a real time, but at least you can get a bit of a earlier sense of what's going on in the claim space. So the BCDA, I've been liking that a lot. And the another data source I like is actually ADT. So the admission, discharge, transfer dashboard, the data feed. I believe many of you may or may not have used this data feed. It's a near real-time data feed that happens whenever a patient goes through a facility event, getting into inpatient facility or post-acute facility or anything. So whenever actually patient gets in or gets out, transferred, this data gets generated and sent around different stakeholders. QHINs, QHINs, they read it. So is another form that is up and coming. So it's a kind of newer development of the HIEs. So as long as you're using the information for these 6 exchange purposes, you can get this data that is available in the electronic records. Treatment, public health, payment, benefit development, healthcare operations, and individual access services. It's still not quite clear in a way that there are a lot of vendors coming up in the QHIN space, but it's a very promising area that we can tap into this information almost near real time, I would say. And another data source I used a lot is a remote patient monitoring data. Remote patient monitoring program has been very popular in Medicare. And I believe actually some of the commercial and Medicaid population have used these programs. But I think it was actually getting a lot of attention under the Medicare program because there was a big reimbursement started in 2020. But aside from the its reimbursement side, I think the data from IPM is very valuable because when you actually look at the blood pressure and the blood sugar and the weight information that is submitted by the patient, auto captured and auto upload it to your system, and often there is a real time, it's very important to have an early intervention of any chronic disease development. Remote patient monitoring was a very useful data source for me. And also virtual care management data. So during the COVID, actually, we did a lot of telehealth and the text messages and all those things. These are also kind of easy to capture in real time. If you are running a care management organization that does a lot of phone calls or text messagings, those are kind of databases or raw data. It's easier to actually get the real-time data than the EHRs. So those care management data, I think can give you a direct, intervention kind of, how to say, kind of scope. So when you actually have those text messages database, let's say, or kind of phone call database, you can essentially pop up an operational dashboard. Who is calling what for what reason? And you can actually build a quick response team to actually gather together for those real-time events as well. And there are a lot of other data sources like external social determinants of health data. These actually include extreme weather or natural disaster data, which can be usually real time, and any community event data as well. Whether there's some big accident, some mountain fire, and something like that, those data become more and more critical in our world. Medical claims and pharmacy claims, those are traditional data sources we all rely on. It's actually it's kind of de facto standard for making any data analytics tool these days. Pharmacy claims is a lot faster if you can get a hold of PBMs. Medical claims, by nature, it actually gets delayed. Medical claims do not arrive if till actually a doctor's office actually filed a claim. So they are kind of from the actual event and they actually receiving the claim, there is always a time lag. Electronic health records, it's a kind of worm. We all hope to get the EHR data. Interoperability is getting better, but kind of always I struggle a little bit to get the EHR data. But I think it's a bit of a case by case. So the EHR data is also very useful data source for making any kind of dashboard in value-based care. So I actually use the same framework for putting the different types of dashboards and put these data sources into these quadrants. And these actually the position of the data sources may change, and they also may change depending on how you want to use them. So it's not a kind of absolute positioning. This is my subjective positioning. I should clarify. But this is kind of the way I see it at the moment. But you can also put your own way and kind of use a similar framework to determine what are the sources actually you want to put in which quadrant, and what are the things you can do. Right? If you are getting into let's say you have an ADT data source, and where would you put it, and what kind of dashboard can you make? And then based on this, actually ADT feed, based on the location of this quadrant, I think I can make an operational dashboard, right? Based on the real-time event coming from the ADT data, I can create something I can act on immediately, right? Same goes for the RPM and care management or execution, right? Some of the other data types actually will just set what kind of things you can do. And a lot of those are actually dependent on the data recency, as we discussed. And I'll get into kind of almost a final topic. So am I doing okay with the time? Yeah. So
Yes.
okay. So why do we need dashboards in value-based care? I think that's the key question actually. I probably should have mentioned this kind of in the beginning, but I just intentionally put this out at the last, because I just wanted to actually put out what is exactly the dashboards are and then why they would be needed in value-based care setting. Value-based care is a kind of a umbrella term, and I think it got popular used by many different folks. And when you talk about the VBC, value-based care, I think at this point everybody has a different idea about what value-based care is. So it's like a AI or some big jargon, big data that people use over and over again. And I think a lot of times we get confused with exactly what they are, like a dashboard as well. So I just kind of bring the kind of one of the more popular definition of the value-based care from the Commonwealth Fund. So the value-based care ties the amount healthcare providers earn for their services to the results they deliver for the patient, such as quality, equity, and the cost of care. And through financial incentives and other methods, value-based care programs aim to hold providers more accountable for improving patient outcomes, while also giving them greater flexibility to deliver the right care at the right time. And that's kind of what they put it. When you look at the CMS website and type what is a value-based care, they have a bit of a different definition as well. When you actually look up the value-based care in a different sites, those things are maybe kind of a little bit different, but I picked this one because personally, I resonate with this definition the most. But kind of besides, why do we need a dashboard in value-based care? I'll take kind of one example. Accountable care organization. So the ACO is one of the most popular value-based care contract. And I believe many of us actually are familiar with the ACO, but just to recap, ACO is essentially a kind of shared organization that provide incentive for the shared savings. And the shared savings or estimated savings are determined by the estimated spending minus actual spending, right? Estimated spending, estimated savings, and all these quantities actually very difficult to understand in real life, right? And there are many different ways to actually improve the, increase the estimated spending or decrease the actual spending or both, right? So we are actually shooting for something very abstract value in value-based care to get paid. And to actually track those abstract values, we need to look at that abstract value from multiple angles, right? So those create the different quality metrics, KPIs, and to track those, because actually we don't know those, the true value. It's not like a fee for service, because under fee for service, we know what we get paid for. We do immediate, we do some procedure. We know what the price tag is. Although insurance may say differently, but we usually know what the price is. But under value-based care, things are not so simple. All the actions accumulate over time, and you get paid, and after for some certain period of time. And to track that abstract quality that you are pursuing, we need a constant monitoring over what you are doing. And that's why dashboard is very important in providing value-based care.
There was a comment in the chat from David. He said it's interesting to include cost of care and value-based care. Maybe can reduce the overuse of imaging and other tests that have replaced clinical judgment, for example, defensive medicine.
So yes. So value-based care with the cost relationship has a bit of interesting history, because it's up to debate, but there is I believe it's the right source that the term value-based care started or coined from the Harvard Business School in the early days. So the value when you say value-based care is actually a value in business. And when you talk about the value, is essentially better quality, higher quality divided by the cost. Is something simplistic value definition. And so the cost is already inherent in the value-based care. And to some degree, it may be a little bit controversial to say, but the reason why value-based care is being pushed by the Medicare or CMS is mainly because of the cost as well. In the end, I think a Medicare fund is about to deplete. We all know that, and our healthcare expenditure is rapidly growing. We all know that, because of the many factors, population is getting older and a lot of different things. So to actually accommodate a lot of these upcoming changes, in the end, we are tasked to reduce the cost of care without sacrificing the quality of care or improving the quality of care. So I think the cost pressure is just the overall, and it's already kind of there. And the question is, when you are reducing the cost, when you are maintaining the cost at least, how can we minimize the quality reduction? While can we even increase the quality while doing it? I think that actually became this central push to the value-based care from the government. That's my understanding. So I think cost of care is kind of inherent in the definition of value-based care, in my understanding. But to some degree, from the patient point of view, that's a kind of it's a nonsense, right? So why would I actually need to even think about those? But I understand kind of where you're coming from, David. Yeah. Hope this kind of answered a bit to your question. Okay, so so the last message is that there is no silver bullet. So meaning that there is no one dashboard that can do everything. And a lot of times we have a lot of different value-based care contracts. There are a lot of different models are being piloted and are being tested. And the dashboards need to be customized for the different environment. And as we all know, healthcare is a very, very local. And the healthcare is a very specific to the target population we serve. So the dashboards will be very different depending on the circumstances you are in and the available resources you have. So we need to just kind of be creative and understand exactly what the dashboards are, and they come up with the best way to assess the current reality, and kind of keep improving the use of the data to improve the operations. So I have some kind of few examples but these I just put together, and this actually ends my talk today. I don't know if you guys actually have any other comments or questions that I can answer. No? Thanks a lot. It was my honor and pleasure to be part of this session. And thanks for all the participation and good questions to think about. And I'll give the control to Sujina and Alina.
Thank you, Yubin. This was such an informational session and very interactive too. I've never seen the participants actually interact to this level in this series. So this was very refreshing to see. Yes, Victoria will send out a follow-up email, and she will include the survey link to just know how we did. And we'll also provide the slides in that email. And if anyone needs a recording, feel free to reach out to us, and we'll be happy to share that with you as well. But with that, this is our last value-based care echo session. So thank you all so much for being with us and being part of this series. And Yubin, thank you so much for being our last presenter, and to close this out. This was wonderful. Thank you so much.
Thanks a lot, everyone. Yeah.
Have a great day, everybody.
We actually have a comment for you, Yubin, from David. He says, there is hope that good dashboards will increase the assurance that patients have received correct diagnosis.
Yeah, no, I think I agree. I believe actually it can do a lot. Not just this, actually, it can do a lot more. Just creating good dashboard is damn hard. Yeah, David, I agree. Yeah.
Okay, if there aren't any questions, then we're good to go. Thank you so much, everyone. Have a nice day. Bye, Yubin. Thank you so much.
Thank you.